Okay. Good afternoon or good day, depending on where you're calling from. This is Joe Gallo of ASPI, and I'd like to welcome you to ASPI's premiere presentation of the AS 101 series. A quick disclaimer: any information that you see or hear during this presentation is not intended as a recommendation, and it does not recommend, it's not be considered as medical treatment. If you see anything of interest, please feel free to contact your own medical team and pursue that with them. If you would now and throughout, turn your cameras and microphones off during the presentation. The only ones who should be on are those who are involved in the presentations. You may be invited later at the Q&A time to participate. But in the meantime, it's very distracting to the rest of the folks if they happen to be watching you enjoy your breakfast or whatever it happens to be. For questions, you may start putting questions into the chat at any time. And when we get to the Q&A portion, you may have your question remain in the chat, or you may get invited to present that directly. And with that, I'd like to then introduce Mark Lichty, the chairman of ASPI.
Thank you, Joe, and welcome to all of you. It looks like we're going to have a good turnout today. This program on rising PSA is the first in a series. We have a coalition of organizations here, including Active Surveillance Patients International, the Prostate Cancer Research Institute, ANCAN, and also Prostate Cancer Canada, and Howard Walensky with his Active Surveiller newsletter. We had noticed a lack of clear guidance for men dealing with the active surveillance journey, and we felt that it's such a dynamic space that we needed to try to fix that. And hence, this is the inaugural effort, and we're going to have more than this, but you're here for the first one. While misapplication of PSA has led to a terrible overtreatment of prostate cancer, still, PSA is about the only tool we currently have for early detection. We have 35,000 men per year that are dying needlessly from prostate cancer, and that's an early detection issue. And that's up from 29,000 just a couple of years ago. And I was just in Washington, D.C. at a conference, and I learned that the Veterans Administration is now recommending a base PSA at 35, which to me was kind of surprising. And I have 3 sons, and I actually plan to suggest to them that they get at least a base PSA at that age. Well, I just had one just turned 40 actually, and I've suggested to him that he get a base PSA, not an annual PSA, but just a base PSA, so you have some baseline data. The thing that folks were confused about, primarily the United States Preventive Services Task Force, is that PSA is just information. It's not a diagnosis. And that was why the overreaction to PSA. This session is just going to deal with rising PSA. And while many of you have already moved beyond that, no doubt you're going to have loved ones or sons or somebody in your life that would benefit from knowing what's in this webinar that we're going to present. And so we'll create future programs. And we're looking for your feedback on this one. As I said, this is the inaugural one, and whatever feedback you can provide will certainly improve the product in the future. With that, I'd like to introduce my good friend Howard Walensky, who wants to say a few more words about the creation of this series.
Well, thanks, Mark. And I do want to discuss how it is that we're all happening to meet today. And it traces back to about a year ago. a group of us involved in support for men on active surveillance had a meeting to discuss programming for 2022. The idea was to avoid duplication of programs. Phil Siegel from Prostate Cancer Support Canada noted that we were not connecting as much as we should with the newly diagnosed, and also with patients in the gray zone, PSAs of 4 to 10, who had not been diagnosed. So we agreed we should develop videos covering the basics for men and their partners who are anxious and up in the middle of the night worrying about what was happening to them, and no support group immediately available. They might not even know there were support groups. So we formed a working group called the Active Surveillance Coalition to develop programs that we called Active Surveillance 101, AS 101, sort of like a basic college course. And you're all going to pass this one. So don't get anxious and don't get worried. The vision was to have real patients and their partners simulate a visit with a top expert in the field and cover the essential questions. Today, Active Surveillance Patients International is premiering the first class for Active Surveillance 101, featuring Larry and Nancy White. Some of you may actually know them, a couple from New Mexico who have been through this process and are a model team. In the video, they're visiting with Dr. Steve Spann, family physician with deep knowledge of PSA testing. Steve is the dean of the University of Houston College of Medicine. The prostate cancer journey often starts with a visit with a family doctor regarding PSA scores. In our programs, we deliberately avoid all PowerPoint slides. I think some of us are getting PowerPoint fatigue in webinars. We try to make this as conversational as possible. The coalition includes nationwide virtual support group for AS from Canada or the Canadian support groups, ASPI, the AS Virtual Support Group from ANCAN, Prostate Cancer Research Institute, and the Active Surveillor newsletter. We owe special thanks to Alex and Peter Schultz and their team at PCRI, who recorded and edited the programs. And just a little more, we have upcoming programs with Dr. Lawrence Klotz, the father of active surveillance, and Jonathan Epstein, the Gleason guru from Johns Hopkins. Okay, so now we're going to air the video and then open up to questions. The video is about 18 minutes long. So Bill, roll the reel.
Hi, I'm Phil Siegel of Prostate Cancer Support Canada, one of the organizations belonging to the Active Surveillance Coalition. Welcome to our new series called Active Surveillance 101, AS 101. We are presenting a series of videos to provide information for men and their partners. We assume these men have rising PSA with suspicion of prostate cancer. Our actors are real physician experts and real patients and their partners. Our program today is called The Rising PSA and features Nancy and Larry White and family physician Dr. Stephen Spann, Dean of the University of Houston College of Medicine.
Hi, Larry, and hello, Nancy. Nancy, I didn't expect to see you today. How are you doing?
Well, we're doing pretty well, I think. Nancy and I've been seeing you for quite some time, but she's not come to any of my visits with you. And when your office called about setting up this consultation concerning a recent PSA, I became pretty anxious. And I could only think that I had a rise in my PSA. And as you know, my dad died of prostate cancer. So as I began to think about all the possible things that could happen, I became quite stressed. And I asked Nancy if she'd join me today, because Typically, when I go to the doctor's office and I get home, she asks me questions. I never know the answers to them, or half the time I don't. And she asks questions that I should have asked in the first place. So I thought I'd bring her along today. So we devised some questions for you so we wouldn't forget. And I'd also ask if we might record this session. So when we returned home, we would have your information and we could talk about things.
Well, it's great to see you guys again. And Nancy, I'm really glad you're here. I think it's really helpful to have couples involved in discussing and making decisions about these kinds of issues. I'm delighted for you to record our conversation today. And Larry, your suspicion is correct. Your PSA is still elevated at 5, as it was when we checked it a couple of months ago. Remember that we wanted to recheck it to see if it remained elevated. So you've now had 2 consecutive PSAs of 5, and that's up from a level of 3 1 year ago. So that is a significant change, and we need to talk about that.
Dr. Spen, could you tell me what is PSA? What do the letters stand for? And also, what is a normal PSA?
Sure, absolutely. So the acronym PSA stands for prostate-specific antigen. And the PSA is secreted by the prostate gland in all men. We do use it as a biomarker for possible prostate cancer. We use it as a screening test for prostate cancer, and we also use it in active surveillance of individuals who have low risk, very low risk prostate cancer, and we even use it to follow people who have been treated for prostate cancer with radiation therapy or surgery. It is important to pay attention to changing PSA levels, and as we can see, Larry's has increased over the past year. Now, a normal level is typically considered to be less than 4, although some physicians use an age breakdown in terms of normal, but most physicians would say, well, if it's less than 4, it's okay, but once it reaches 4 above, that's elevated, and we need to pay attention to that.
Well, Dr. Span, how accurate is the PSA test?
Yeah, great question. Go ahead.
Well, just wondering, I mean, we did have 2 in a row, but, I really don't know if it's accurate enough for me to jump to conclusions or not, or what.
There is no perfect test in medicine. There's variability from test to test sometimes, just natural physiologic changes in biomarkers. And so one day they may be normal, another day elevated. And tests always have a potential of having a false positive, meaning that they're abnormal when no disease exists, or a false negative, meaning that they could be normal in the presence of disease. So there is no perfect test. And that's one of the reasons that we repeat an elevated test within several weeks, just to be sure that it remains the same. Having an elevated PSA does not necessarily mean that you have prostate cancer. But when you have 2 elevated tests in a row, we start to pay attention. Does that make sense?
I think so. So we're not going to jump to conclusions yet.
Right. I don't think we can jump to any conclusions at this point.
Because Nancy and I were wondering, does that high PSA mean that I do have cancer? So I think you're kind of helping us with that.
It does not necessarily mean that you have cancer. The only way to find out really is to do a biopsy. That is the gold standard, as we say. But increasing elevation of the PSA does make us concerned that cancer could be a possibility.
Well, are there certain things that Larry should do or not do before a PSA test to be sure that it's accurate?
We have to consider other things that can cause elevation of the PSA. One of those is infection. Um, you don't have any symptoms of infection. One of those is just a large prostate. We call that benign prostatic hypertrophy. All of us as guys, as we get older, our prostates get bigger. They grow out as well as in. And a large prostate can secrete more PSA. And so one of the ways we look at that is something called PSA density, where we actually do an ultrasound of the prostate to see what size it is. And then we look at the ratio between the PSA level and the density of the prostate to see what the prostate density is. If you have a large prostate, that could account for some elevation in the PSA.
Well, one of the things that I've neglected to tell you about is that I have had more difficulty urinating, more difficulty to start urine flow, and then to my stream is small, and then sometimes I'll dribble when I go to stop. So, I was kind of concerned that maybe that was about cancer, but I think you're saying that it could be. What was it? Benign prostatic hypertrophy?
Benign prostatic hypertrophy. Exactly. So, again, as the prostate grows, as we mature, I like to say mature and not get older, it grows out and in, and it compresses the urethra. The urethra is the tube that carries the urine to the outside, and so as that gets compressed, there's some obstruction, and so you're urinating against an obstruction, so to speak. So what that means is that your stream is less strong. Sometimes it means you even dribble. It also means you don't completely empty your bladder, so you probably urinate more frequently than usual, may even get up at night once or twice. Now, that's pretty common as we mature. It can be a symptom of prostate cancer, but not necessarily, because many guys who have large prostates, benign prostatic hypertrophy, have these symptoms of obstruction.
Well, I guess a concern of mine is another concern, actually, is that, we have two sons and a daughter, and, my dad had cancer. I think I've been thinking I'd probably have it. I don't know. My level of anxiety is really kind of going up, but should I have genetic testing of some sort to see if there's any issues that might cause my children to have problems, or even my sons? When should they have their first PSA? How do we proceed in that area?
Well, Larry, let me first say that I think your anxiety, your concern is a normal human reaction. I don't want you to get overly concerned, but I want you to be concerned enough that we do all the right things to check this out, right? And it is true that when an individual has a first-degree relative, meaning a father or a brother who has had prostate cancer, that person's risk of prostate cancer is higher than average. So that is true. There are some genetic markers that we can do to look for increased prostate cancer risk. And we could do those markers on you. That wouldn't necessarily change our thinking about whether or not to do a biopsy, though. There are some markers such as BRCA1 and BRCA2 that could be important to do, because that could indicate a risk in your daughter for other types of cancer, ovarian cancer, breast cancer, and so forth. So that's something we might want to consider doing. Yes, you have some increased risk. Yes, we could do biomarkers, genetic markers. Having said that, we really ought to think about having a biopsy done.
Well, again, my anxiety, I think, is kind of escalating maybe more than it should, but where do you suggest we go from here?
Well, I think we need to refer you to a urologist that is up to date on the modern testing and treatment of prostate cancer. The good news is that a lot of patients who are diagnosed with prostate cancer have very early stage cancer, very low risk of that cancer advancing to something more serious. And many of these patients choose for something we call active surveillance, meaning that you really don't have to proceed to treatment, that because the tumor may well grow very slowly, that it can be watched over time with repeat PSAs, with repeat MRIs, occasional repeat biopsies. So I think we need to send you to a urologist who will carefully evaluate you. That would include likely an MRI guided biopsy. And then based on the results of that biopsy, talk to you about treatment choices. One of those would likely be, in the case of a low risk or very low risk tumor, active surveillance.
Active surveillance sounds like a reasonably good possibility for me. I mean, I've even been hearing that prostate cancer has been overdiagnosed and perhaps overtreated. And so, you know, we certainly trust you. I don't think I want to be overtreated or undertreated. You know, so, you know, perhaps the active surveillance group, something like that might be reasonable for me. So I guess the next thing we do is be referred to urologists.
I think that would be the next step. You know, it turns out that there is some controversy even around screening for prostate cancer. The U.S. Preventive Services Task Force recommends that men receive all the information about the benefits versus the potential harms of being screened and make a personalized decision. It's a very personal decision. The good news is that most men who are diagnosed with prostate cancer die with it and not from it, because most of these tumors are very slow growing and do not end up causing major problems. The issue of overdiagnosis and overtreatment has to do with the fact that some experts now believe that, in fact, we have been over-concerned about those early cancers and overtreated them, and that for many men, a better option, a better choice would be active surveillance. We can refer you to a urologist who will go over all of this information with you, do the right tests, and you and Nancy can decide together what would be the best treatment plan for you.
Okay, well, you know, we really appreciate all the information that you've given us today. And I think we do need to go home and talk about this. But I will say, after my dad died of prostate cancer, I've just been leaning on once it came up with it for me, I was just going to get the dadgum thing whacked out of there and move on. But I think after our discussion today and kind of information that we're getting, that might not have been a reasonable approach. And I think I need to continue further on and find out the different options and kind of go on from there. And active surveillance is something that I've not thought that much about. So I think that's a reasonable thing to think about. But I will tell you, I don't want to die of cancer. So I guess we'll try that and try to figure it out. And we may be, trying to talk to you again once we see the urologist, even to run things by you, because you're someone that we definitely trust.
Well, I am confident that once you've had the right tests, the biopsy, you will be presented with all of the treatment options, and you may well decide that active surveillance is the best option for you. And I want you to know that I'm going to support whatever decision you make. I also want you to know that I am here to answer any questions, to discuss more if we need to, that I am confident that you will make the right decision for you, and that will be okay.
Well, and of course, it's going to be the decision for me, but for Nancy and for the family as well. Clearly, this is a family discussion for us. And again, we really appreciate your help.
Thank you.
Well, I totally support that, and just glad to be of help.
Okay.
We really appreciate it. Thank you.
I'd like to thank Larry and Nancy and Dr. Span for their excellent presentations today. This presentation was recorded and the videos will be available on the ANCAN, ASPI, PCRI, and Prostate Cancer Canada's website. Also, please stay tuned for further episodes of Active Surveillance 101.
So I was reflecting on this as I was listening to the program. I realized that when my GP told me that I had a rising, suggested that I have a PSA test, he never spoke to me at all about what might affect that PSA test. Anything from riding a bike to ejaculation and a couple of other things. And it would be interesting too to hear from you about whether you folks got any notice about things that might affect it. Even the lab where the PSA is done, there's sometimes difference in results from the lab. So since this is the inaugural session on this, we wanted to hear from you too about, is this the kind of thing that you might share with somebody that you know of that has a rising PSA? Would this be helpful to them? And if you want to, feel free to raise your hand, and we'll call on you. I'm reading one here, one question that just came in. I had a biopsy that found cancer in one of the nodes. My Gleason score was 3+4. My genetic test results indicate low risk. My urologist is recommending active surveillance. My question is, why not just treat the cancer by radiation now and not have to worry with repeated testing with the uncertainty? Well, the trend strongly on 3+4 now is to consider active surveillance even with a 3+4, and it has to do with one's own anxiety. And if you are able to deal with your anxiety and be in a place of what we call peaceful vigilance, and that's many of us on this with PCRI and ASPI and all of these have found a place of peaceful vigilance where there's very little anxiety. And the issue is how to get to the other side of that anxiety. If you can get to the other side of that anxiety, then staying with active surveillance may well work for you. And again, you have to keep in mind too, you speak of radiation in your question here. Radiation can have long-term effects, many different long-term effects. And sometimes the radiation side effects don't show up for a number of years. So those are things that if you're thinking about treatment, we think, oh, okay, the cancer is going to go away. Well, maybe the prostate cancer will go away, but maybe some other side effects will show up later on. So those are things that.
Hey, Mark, can I weigh in on this too?
Anybody can weigh in. We're
Okay.
all.
Yeah, for Greg, there's other factors that you have to consider too. I mean, there's 3+4s and there's 3+4s. You know, you have to look at the percentage of invasion of cancer that you have. In other words, if it's only 10% 3+4, it's far different from having something that's 50 or 80% 3+4. And another factor to consider is your age, you know, and as Mark was saying, your peace of mind and, you know, whether you're anxious about it. It sounds like you're getting some very positive signals, Greg. By the way, we're not doctors. We don't play them on television or on video, but you're getting some very positive signals from your urologist. Your urologist is saying that active surveillance is a choice for you. And of course, the other choice is you can be treated. And so it comes down to, your decision, consulting with your partners and family and friends. Do you want to face risks? I mean, radiation therapy has really improved. Most men in our situation with low risk prostate cancer, 60% of us in the US versus 90% in, say, Sweden, go for active surveillance. With 3+4, about 20% choose active surveillance overall. So, you got to weigh your decision. Do you want to take the risk of, I don't know, you can get fecal incontinence as a result. There's risk factors. It potentially could harm your sex life. So, but you're the one who's going to live with the consequences. One thing that you can say about about prostate cancer is generally it's slow growing. So if you monitor this through an active surveillance program, you're going to get an early warning generally that it's time to act and have radiation. But if you want to have radiation tomorrow, that's sort of your choice. But I would think about it carefully. And I don't know, Greg, if you know what percentage you are of 3+4, but at any rate, I see a couple other guys that, we could open up the floor, I guess, if anybody else wants to comment to Greg.
Sure. And just wanted to mention that, was it Marvin? Yeah, Marvin suggested that we do a follow-up session with a urologist, and he's thinking just like we're thinking. We already have that one in the can, Marvin. So
actually, we have two in the can.
Yeah, we've got two in the can. So
Dr.
stick around for the next session. We'll be sending you a notice of it when it shows up. Do we have any hands raised? I don't see any hands raised. There's a comment on finasteride. Yes, that does reduce the size of your prostate. I tried finasteride years ago, but I've been on active surveillance for 17 years. Probably 16 years ago, I tried, but it affected my sex life, so I quit doing it. I'm not advocating that you do, but I just wasn't particularly enamored of the finasteride. What advice about fluctuating PSAs from a little above 4 back down to 3 range over several years? Several 4K scores came in at 7% risk. I never had a biopsy or MRI to date. And this is from Jim up in Maine.
It's not unusual to see fluctuation.
Yeah.
Mine 12 years ago hit 3.95, and I was put on the biopsy train back then. Annual biopsies were common, and I did that for about 4 or 5 years until I stopped doing it. But so a little bit of change in this is not unusual. Mine eventually went up to almost 9, and then it came down, and it sort of stayed at 4.5 for recent years. So there is such a thing as PSA anxiety, and Jim, yours sounds like it's fairly stable within a range. So I don't know if you're anxious about this or what, but it sounds like you must have a pretty good doctor who's not pushing biopsies on you.
And Marvin, I see your family physician had suggested that you get a biopsy. In many places, they're suggesting less invasive procedures initially, either an MRI or in my case, I had what's called a micro ultrasound down in Fox Chase in Philadelphia. And that the data, the studies that are coming in indicate that the micro ultrasound is as accurate as the MRI, but both of those are much less invasive than the biopsy. And those of you that have stuck with us know that we've had programs on the transperineal biopsy, which doesn't present the risk of sepsis that the transrectal biopsy has. And so if any of you are at that stage where you're trying to make a decision about a biopsy, please visit our webinar about a year ago on transperineal biopsies. Oh, there's a raised hand. I don't see the raised hand. Is that?
Yeah, Jeff Fino has a raised hand.
Well, let's call on Jeff. Speak. Go ahead.
Okay, I'm here. Thank you. Thanks for having this, by the way.
Yeah.
I wanted to follow up with Howard. He had mentioned that he was doing annual biopsies and then stopped. What was your experience after that? Did you do them less frequently or not at all, or what?
Well, I mean, if you want the, I'm just speaking for myself and what I did. 12 years ago at Johns Hopkins in Baltimore, their standard was annual biopsies. They were being super cautious. I was going to the University of Chicago, and my doctor there was following the Johns Hopkins protocol. And so my first year I had two. The first one was ambiguous. The second one showed a single core of Gleason 6, and it was less than a millimeter. So it was like a speck. And at any rate, and so for 3 more years, I think after that, I had annual biopsies. Finally, my doctor said, we know your prostate pretty well by now. And so why don't we take a vacation? So we took a vacation, and I ended up switching doctors, which is a whole other story. And my new doctor wanted to get a baseline. And so he gave me an MRI and he gave me a biopsy. Neither one showed any evidence of prostate cancer. In fact, over all of those years, all those biopsies, I've had, I think, 6 biopsies in 12 years, and only one of them showed that tiny speck of prostate cancer. And, that tiny speck is enough to change your life and redefine you in terms of insurance and in turn, just in terms of yourself. Suddenly you're a cancer patient, even though you barely have cancer. And even though many doctors don't even consider Gleason 6 a cancer. But at any rate, I'm a medical writer, and I do a newsletter called the activesurveiller.com. But for 26 years, I was the medical reporter at the Chicago Sun-Times. So I'm quite accustomed to reading medical journals. And about 6 years ago, I read an article by a doctor who I and several of us have come to know, Carolyn Moore from University College London. And she was proposing that about 5-6 years ago that MRIs should be done first before biopsies. And it was kind of a new approach. I'm not crazy about MRIs. I get claustrophobic, but I can handle it. But so I went to my new doctor and I said, okay, here's this study from New England Journal. And he just sort of blew it off. I said, guys are really getting upset about all of these biopsies. I said, if doctors like you don't change what you're doing, you're going to have a rebellion on your hands. And he just sort of huffed at me again. And he said, well, I think his exact words were tough.
Steve, I saw that your PSA was 6 and your prostate is 145, and that prompts me to speak about PSA density. ASPI has been concerned because the urologists have not universally adopted the notion of PSA density. And if you put your PSA number of 6 over the size of your prostate, 145, you're going to be well below 0.15, which is kind of the cutoff of concern or any other further action. The size of the prostate, the bigger the prostate, the more PSA that you'll generate. So don't let your urologist just speak about PSA. Your urologist, once you've had a transrectal ultrasound, he knows the size of your prostate. You probably know the size of your prostates too. And insist on speaking of prostate density. That's a message that the ASPI has been trying to get out. Let me see. Alan's been here wanting to speak.
Yeah, Mark, I got reconnected. If I
Oh.
could just finish my thought, sorry.
Okay.
We're having network problems here, but at any rate, my doctor said to me, you know, I fully expected him to tell me it's time for another biopsy, and he didn't. He said, you know, your PSA has been stable at 4.5 and 4.5 to 5. He says, we're going to just monitor you with a type of PSA test called the PHI test. And he said, if you have a spike in that, then we'll do an MRI. And if the MRI shows something, then we'll do a biopsy. But he said, you know, you're so stable and your risk is so low, I don't think you may ever have a biopsy again. So that's my story, Jeff.
By the way, we wanted to remind you that if you do want to raise your hand, we enjoy that and it creates more interactions. If you just go to reactions at the bottom of the page, you'll see the hand raise thing, so you can go ahead and raise your hand. Alan, you've had your hand up. You must be getting tired with your hand up all the time. Why don't you unmute yourself and speak? You're still muted, Alan.
Yep, I am not. Now I'm not.
Okay.
Earlier, I raised a question as to whether having someone who has a family history of prostate cancer would be seen as comparable to someone who has no family history of cancer, whether they might not have a different concern about prostate cancer. For one thing, someone mentioned about a primary care physician recommending a biopsy. I certainly would stay away from that. I would not do anything of that sort without a urologist having looked at the situation.
Yeah.
Unless you're convinced that unless your primary care physician happens to be a urologist.
No, I totally.
So those are.
Yeah, totally agree. And yes, the family history is relevant. I mean, years ago, it used to be all about your genetics and your family history. And my father did die of prostate cancer. And so for a number of years, actually, I too was very concerned about it. But then this idea of epigenetics came about, and epigenetics just means that there's things that operate above the level of the genes. And so we can alter the course of our prostate cancer. And in my case, I did a lot of research and I went on a vegetarian diet. And that's how I've dealt over the past over 17 years with my prostate cancer. So yeah, the genetic history has some impact, but it's not the only game. You can change the course of your prostate cancer if you choose to.
Well, and Mark, in terms of genetics, you know, I'm going to give a plug for, well, first, just not everybody may be familiar. Your cancer has its own DNA, you know, and there's something wrong with it. You also have your own DNA that you inherit from your parents. And so it could be worthwhile to take a DNA test. And there is a free one available if you sign up for the PROMISE study. I signed up for the study and got news last week about a different issue about colon cancer, and I was carrier of a gene for colon cancer, low risk, and so you never know what you're going to find, but it could be worth your while. I don't know if we can put up the promise link, at any rate.
And we did do a webinar just last month on that whole genetic testing issue. So if you want to check out our webinars, you'll see a really good webinar on that subject too.
By the way, we should take note that Greg only had a single core of 3+4 and only 10%. So this is very low risk, Greg. You should really talk it over with your family, especially since your doctor is recommending active surveillance. You might think twice about taking any risk from treatment.
Well, how about Norman's got his hand up. Norman, do you want to speak?
Yes. Can you hear me?
Yeah, perfectly.
Oh, okay. I've been in active surveillance for about 13 and a half years. And I believe that I've been overdiagnosed and overtreated. I had biopsies starting in the year 2002 all the way through 2014. So over a 12-year period. And what I mean by overtreatment, these biopsies have given me problems. I believe that in all the biopsies I've had, 5 of them, they removed about 70 cores from my prostate. The only one that found any prostate cancer was in the biopsy that was done in 2009. But in that biopsy, they took 27 cores, and they had to put me to sleep for that. What this has done for me or given me a problem is that my primary care doctor believes that I'm very prone to prostate infections now. And he claims that the bugs hide in the little holes in my prostate or in the scar tissue. And he cures the problem by giving me antibiotics. And after some antibiotics, the problem goes away. But it's prone to come back. And that's what I mean by overtreatment and overdiagnosis. Eventually, when they found the prostate, it was when I had the 27 cores. 2 out of the 27 cores showed a little bit of cancer. 1 core showed 3% cancer. The other core showed 9% cancer. Both of them were 3+3 on the scale. So that's my experience, and the problem is getting too many biopsies. That's what it did to me. And I've got problems ever since because of the frequency of prostate infections.
I'm sorry to hear that. That's not uncommon, unfortunately. 16 years ago, I stopped having biopsies because I was concerned about sepsis. Now, sepsis is not what you have experienced. Sepsis is far worse, and people actually die of biopsies. But it's not uncommon to hear of prostatitis. And again, with things like administration of antibiotics to deal with the prostatitis, antibiotics are destroying your microbiome, and then you have to spend months rebuilding your microbiome. So you might want to, if you have a biopsy happy urologist, you might want to look around for another urologist, because as Howard said earlier, we're finding more and more people are considering less invasive ways to monitor the cancer. And by the way, your incidence of cancer is very small, 3% in one core and 10% in another. That's not a lot of cancer. But again, I'd be thinking about looking around for another urologist. Paul's had his hand up for a while.
Yeah,
Paul,
hi. So I put a little bit of my story in the chat there, and I just thought I'd just throw it out there to, you know, if people want to invite some comments, because my journey started probably about 2.5 years ago. I live here in Canada, and my PSA was going up steadily over 2 or 3 years. I had an ultrasound done just to check the size of the prostate, and based on that, my GP told me, well, you know, that explains your PSA going up because you've got a very large prostate. Eventually, though, when it hit 7.25, I said, you know what, no, I need to see a urologist. And he said, no, absolutely, you needed to see me. Make a long story short, I ended up with a biopsy, and 3 cores came back positive for the prostate cancer, and he put me on active surveillance. My PSA level jumped. He said he would see me every 3 months. Between that one, the PSA of 7.25, and the next visit with him, it jumped to 16.25. And fortunately, that's a problem when we have access to blood test before seeing the specialist, because I saw the result had jumped to 16.25, and I didn't see the urologist for another week. So as you can imagine, I was just totally anxious about it. When I saw him, he told me that another name for PSA is please agonizing, to which I felt like saying, that's because it's not your prostate, but I didn't. So he did decide that, he said there are many reasons that could account for that jump in your PSA. So I wanted people to know it could come out that I have something, that the cancer has spread. But he said that there are other reasons why it could have jumped, he said. And he didn't seem very alarmed, because he said the cancer wouldn't spread that quickly, because it is, as some people have mentioned, it is a slow type of cancer. But he has arranged for me to have an MRI, which we'll have on Thursday. And I guess that's the whole thing of the active surveillance, you know, because now I know that, you know, if he had said to me, that's it, we're not going to do anything else, I wouldn't have been happy with that. But at least with the MRI, he said he wanted to rule out the possibility that, because with the biopsy, it takes from the anterior, and he wanted to see if in the front of the prostate there might have been something. So that's where I'm at, and I just wanted to mention that, so that, you know, because the active surveillance, part of the active surveillance is the PSA, and it can be very, very agonizing, and just wanted to put it out there if anybody.
Totally understand when it jumps that much, but it could have. Did your GP give you any counsel about not riding a bike or not having sex or ejaculating? Did you get that kind of?
No, my GP was very laissez-faire about it. Just kind of like, no, your prostate is just very large, and so I insisted then that, you know, no, I want to see a urologist on this, because I was having other signs like ED and frequent use of the washroom and so forth. And when I went to see the urologist, to be quite honest with you, I thought the urologist was going to tell me, because the GP had almost convinced me that I shouldn't be worrying about this. So when I went to the urologist, I thought he was going to tell me that I was no need for me to be there, and he was the opposite. He was actually quite upset about the GP that she hadn't sent me there earlier. But thank goodness it doesn't. I didn't have many cores with the cancer, but it could have been a different story if because it has been going up for the last 2 years. So if you know, if things could have been very different, I could have found out that it was quite bad, and it could have been seen years ago, right?
Yeah. Well, let me come back. One thing I want to say, that then Phil, you can speak. I just want to, there was a question in here about what I mentioned about the density ratio. And again, for the density, you put the PSA over the size of your prostate. So Paul, if you did that and you have a large prostate, if you're still under 0.15, you may be in good shape. But the counsel that you got about getting an MRI is not bad counsel either. Yeah, Phil, go ahead. What was on your mind?
Yeah, I just wanted to ask Paul, where are you being treated?
I'm being treated at Credit Valley Hospital.
Okay, are you part of any prostate support group in the GTA?
Yes, I am. Yes.
Okay, good. No, I just wanted to make sure. And also, have you inquired about transperineal biopsies?
So what the doctor told me on my last visit was that depending on this MRI, if they do see anything that they missed on the biopsy, that with the MRI, they'd be able to measure exactly where it is, so that if they decide to go in for another biopsy, they'll know exactly where to search.
Yeah, no, but if you do have to do another biopsy, which I hope you don't have to do, you might want to consider transperineal biopsy, which is avoid some of the issues that other people have been talking about.
So it's called transperineal?
Yeah.
Transperineal, yes.
Take a look at our webinars. You'll see one about, as I said, about a year ago, and that's a really good webinar.
Okay.
That's if I were.
And
go ahead.
Yeah, and the last comment I have is that the Prostate Cancer Support Canada, we have an active a group that's devoted exclusively to active surveillance. We meet once a month, Paul, and you may be interested in joining that group, because there you'll be talking to people who are exclusively on active surveillance.
Could you, Phil, put the link to that group in the chat there, or
yeah, I will.
Okay, appreciate it.
I'll do that.
Thank you very much.
So somebody here Doug asked the question. He's 81 and he's been treated, and he wants to know whether he continues his PSAs at the age of 81. And that would be beyond because you've been treated, that would be beyond our ability to give you good counsel. But I will say that while ASPI is dedicated to encouraging active surveillance, we also encourage treatment where it's called for. In fact, we've got 2 men on our board that have progressed beyond active surveillance and have been treated. So we're very supportive of treatment if it's called for. I guess we have another hand. Norman, did you have another question, or didn't you put your? I think we answered your question. I'm not here's a question. I'm not an anxious person. I sleep through the night. So you are lucky, because I don't sleep through the night. I got up 3 times last night, and you'll have to tell me later how you do that. Here's a good book recommendation for those who may be concerned. It's Midpoint, Manhood and Midlife. I hadn't heard of that before. Okay, well, thank you for that. That's by James Hill. And is that a pretty recent publication? Who is it, James? Well, that's all right. You don't have to respond to that, Jim. Paul Murphy. Alan, are you back for another question? Or I guess he's good.
Yes. I have a comment. Just
okay.
I think one of our problems is that the first time people hear about anything having to do with the PSA is through their primary care physician, and too often they either know absolutely nothing about what a PSA involves or don't have the right information. Either they have to have the right information to be able to counsel someone so they don't start off with concerns and fears and anxieties. They should have enough knowledge so that they can say, don't worry about the PSA, which is higher than we would really like, because they don't even know that the PSA standards have changed from what they were once upon a time. When I was diagnosed, it was 4 was the magic number. It's not the magic number anymore anyway. That's
Correct.
all.
Mhm.
Since Mr. Allen is on here, I might ask him to talk a little bit about continuing with PSAs in your 80s. Alan, do you have something to say about that?
Yeah, my urologist still recommends it, even though I think he thinks we're finished with any consideration of that.
And what do you think about that? No comment?
Am I being heard now?
Yeah.
Okay.
Yeah.
Did I for the
You
period
please-
that I've been on active surveillance, my urologists, because I've changed once, have always recommended twice annual PSAs, and my current urologist is, for the moment, is still doing that, which is fine with me. But he's really not, he's only concerned about a significant increase in PSA over a short period of time. But he still sees it as one of the modes of making sure there is active surveillance happening correctly. But I think at this point, we're probably almost finished with doing PSAs. 82 now.
Mm-hmm.
Well, and there can be a transition. And I'm going to be 75 next week. And yes, you can sing happy birthday. But my doctor is telling me that I'm sort of transitioning into watchful waiting. In other words, as Alan was saying, if something dramatic happens to my PSA, and I'm not saying anybody else is in this situation. He said if there's a dramatic rise, then we might get more aggressive with MRIs and so on. But it's an issue for guys in their 80s. I was talking to Dr. Cooperberg at University of California, San Francisco, and I said, is there a time that guys should get off the bus with all of this surveillance? He said, it comes down to the doctor and patient deciding. And he was telling me he has a 101-year-old patient who's on active surveillance, who unfortunately is now developing a more advanced cancer. And so do you operate on a 101-year-old man? So there's a lot of issues here to consider. But, and I know Alan has more of a fatalistic view towards all of this. He's lived a good life. He's square danced his head off or his hips off. And, I don't know where he's at with this now, but he's talked frequently about not ending it all, but ending active surveillance. So, Alan, I don't know if you have anything to add to that.
Well, I was curious too about the men on this phone call. One of the things, and one of the reasons that ASPI is here is that we find that there's a lot of men that don't have to go off of active surveillance. They just go off because of the anxiety of this process. I'm just curious, is there anybody on this call that is thinking about getting off, is so anxious that they're thinking about getting off of active surveillance? If you feel like sharing something about that, just raise your hand. We got Alan. Norman, did you want to speak again?
Yes. Can you hear me?
Yeah.
Okay. I wanted to react to some of the things that just came on. I'm 82 and a half years old. I still take my PSA about every 3 or 4 months, and I don't ever intend to stop it. And I haven't been treated by one doctor that's PSA, or rather biopsy happy. My last biopsy was in 2014, and in that biopsy, they found no cancer. The only time they found my cancer was in my third biopsy. I think it was my third one. I had them in 2002, 2004, 2006, no cancer. In 2009, so it was my fourth biopsy, where they took 27 cores. The only reason that happened was because my regular urologist, I complained to him and said, "This is pretty painful. Can you put me to sleep?" And he said, "If you want to get put to sleep, find another urologist." So I did.
Mhm.
That urologist, unbeknownst to me, was going to take 27 samples. And I think that caused all of my recent problems with frequent prostate infections. And the other thing that I've had done throughout is I've had at least 5 MRIs. The most recent one was in the month of August this year. And that I spoke to the radiologist that looked that over, and he told me there's nothing wrong with your prostate that we can see. So that's where my doctor goes when he feels that the PSA is not giving him the right information. He tells me to get an MRI. And I've also had some other treatments. I forgot the name of it, but they use radioactive fluoride. And I forgot the name of that procedure. Axumin, that's what it was. Axumin scan.
Well, it's
So
interesting.
I just want to correct the idea that I'm being treated by somebody that wants to keep doing biopsies. I was told after 2014, don't get any more biopsies.
Yeah, it's interesting to see the evolution of the whole prostate cancer space. I mean, first, in the past 10 years or so, we've realized that there was an epidemic of overtreatment of prostate cancer, an epidemic maybe like no other overtreatment of any cancers in our history. But then we're now just countering an epidemic of overtreatment, of over biopsying. And over biopsying, it has all the consequences of sepsis. If it's a transrectal, it's got the, has the issue of infection that you're speaking of, Norman. And I don't know that anybody, I actually only had 2 biopsies years ago, but I don't know that anybody ever told me about that possibility of prostatitis. I don't think I had any notice of that at all, and that's one of the problems that we've seen is the inadequacy of notice with regard to side effects, and we need to all demand more and better notice of side effects, whether it has to do with treatment or whether it has to do with just the monitoring, the biopsy. We've even been concerned, but we haven't pursued as much. We've been concerned, ASPI, I'm not speaking on behalf of the coalition right now, but ASPI had been concerned about the use of gadolinium as a contrast agent, because there were some side effects that it turns out that, and by the way, I've had gadolinium applied to me. I quit doing that because, well, I haven't had any biopsies. Well, even with the MRI, they wanted to use gadolinium. And ASPI doesn't have a clear position either. I have my own personal opinion on the use of gadolinium. And I don't want to use them because there's not enough data for me to assess that gadolinium is safe. The jury's still out on that, but I think other members of our board probably would use gadolinium. But my point is not about that. I don't want to dwell on that. My point more is the need for better notice from the medical profession about side effects.
Mark,
Yeah.
I just wanted to ask Norman a question about his PSA levels. Is one of the reasons that you've had the repeated biopsies because your PSA has been going up?
Can I respond to that?
Go ahead.
Okay. I had my PSA was rising slowly over the first 3 biopsies. 3 biopsies happened in 2002, 2004, 2006. And they continued to rise, but they could find no prostate cancer. It was only in 2009 when they took 27 samples did they find any prostate cancer, and it was very, very low. Both were Gleason 6, and there was only 4% cancer in one sample and 9% in the other. But that's why I had so many biopsies. In 2014, my oncologist said that you ought to get another biopsy just to clarify everything. And when I did that, it was done by Dr. Duke Bond, who used color Doppler imaging to decide where to take samples from your prostate. And he found no cancer. So I feel pretty safe on active surveillance because of that. But I feel like if I had done the right thing previously and got less biopsies, it was only one big biopsy that really caused the problem, I think. And on my MRIs, I've had gadolinium every time, and I had at least 5 of them. And I didn't even know enough to be concerned about the gadolinium. So that's my history.
Yeah, it's interesting
very
about
much.
it's interesting about color Doppler. I did have one of them with Duke Bond years ago, and so color Doppler had traction out there in California, and not too many other places either. And I still, after all of these years of color Doppler, that monitoring method has really not gained traction. And I I don't know if anybody here knows why, but if they do, I'd be curious. It did see you got the results right away, and you saw the red, and you could see everything that was going on, but it just never got any traction for some reason. Oh, here's a new name, Arnold. Arnold, you want to speak? Unmute yourself, Arnold. You're still muted. Still muted. Okay. Well, I can tell you. Whenever,
now?
Yeah, that's good, Arnold. Go. Yeah.
I went to Dr. Bond also, and I got the colored Doppler, and I thought that was one of the greatest things because that's sort of along the lines of a targeted biopsy. I've had random biopsies after random biopsies that they could never find the cancer. And with Dr. Bond, with the colored Doppler, they found it. It was relatively small. And then when I actually went for my procedure, I went on the HIFU, and I can't remember the doctor's name now. Anyway, when I went out to Sarasota, Florida to have the HIFU done, and the biopsy there was with the, what is that rocket that's supposed to go up to the moon? Atrium, Artemis, the Artemis type of biopsy, which is a targeted biopsy. And I spoke to that doctor, and I mentioned Dr. Bond, the colored Doppler, and he went up and down about the fact that that is not a true targeted biopsy. So he said that is something in between, and he went on the fact that, I said, I don't ever want to go through a random biopsy again because they're just got a grid system, and you try here, here, here. And with the colored Doppler and with the targeted biopsy, they look for where the lesions are, and they go right where it's at, and they always find it that way. So that's what was explained to me as far as colored Doppler.
Thank you. So there's a question here from Feliciano. Did anyone have genetic testing on their biopsy cancer material to see how aggressive the cancer is? Well, that would be probably genomic testing. And I know there's several people, including Joe and others, that have had genomic testing. I never had genomic testing. It's rather expensive and not always covered. I don't know. Does anybody want to speak to the genomic testing or not, and whether they found it useful?
This is Steve Saker. I had genomic testing back in 2013, and I found it very encouraging, and it kind of supported my decision to go on AS. I'd been in some doubt perhaps at that time, but when I saw the results, I was very encouraged, and at that time it was pretty new, and it didn't actually cost me anything. I can't remember why, but it never actually cost me anything at all. Company in California, Oncotype DX, and I mean, I can share the results. I can, if you want to do a screen share, I can show you the results and show you what it looked like. This is kind of old science now because it's close to 9 years old.
Yeah, thank you for the offer. I don't think that's necessary. In any event, the important thing is that you got information that was useful to you. And there's at least 3 different leading ones: Polaris and Oncotype, and oh gosh, the third one escapes me right now. But generally they're not covered. But you were pretty lucky; yours was covered. Oh, I guess we got another hand raised. Jim Clay, you want to speak? Unmute
Yes,
yourself.
I had Oncotype as well, and I think 18 was my number on a 0 to 100 scale. And I also did the Promise genetic testing, and all the genes that they tested showed no mutation. So that was really nice news to receive. And my insurance, Medicare plus my supplement, covered the whole cost for both of those procedures.
Great. Well,
Can I chime in one more time?
Go ahead.
Arnold. I did all of that, and there's also another one online called color.com, and they will check 30 different type of mutations of BRCA1, BRCA2, and about 28 different types of genes in your body. And it was pretty interesting. It cost about $250. I did that about 3 years ago. The whole group our group in Hawaii, a lot of people did the same thing, and it came back all negative. So I gave that to the doctor, and he said, well, at least you don't have the genes. But then again, there's a somatic gene pool where, because of your environment, like in my case, I was told that I've got prostate cancer because of Agent Orange exposure. So that's a different story. But I asked if I had to repeat this kind of testing, 10 years down the line. They said, no, what you got is what you got. So that was pretty interesting. And that cost $250.
Yeah, well, Arnold, that test is available for free now. To any of us who have been diagnosed with prostate cancer, if you're willing to go into the Promise study. I don't know that you go into the Promised Land, but just to keep things straight, what you were talking about 2 different things. The color study, which is available free now, is looking at your personal inheritance of genes.
Yes.
Previously you were talking about the genetic makeup of your cancer, which is different. 2 different things. But I'm going to dig up a link for the Promise study, and I'll put it up there.
Thank you.
Oh, I found it. Okay.
Oh, okay. Well, so we've been going on for, well, actually nearly an hour and a half. And unless anybody has, Moses, well, let's recognize Moses. Moses is a very,
Hi,
yeah, go ahead, Moses.
my name is Moses, and first time of joining you guys. I live in the state of Maryland, and I am with John Hopkins. So I've been on this thing for 3 years, but I've had the biopsy 2 times. Both times my glycine score they've been like 6, and I've had MRI 2 times, and the results pretty much same. Actually, my second MRI that I had last month is a little bit better than the first one that I had in 2020. So, but my question to the group is, I have had a lot of encouraging news or information. I wanted to know who here had been on the AS the longest, and how often or how often did they take the biopsy, and when was the last time they had the biopsy? And my last part of the question is, does anybody here have ED after the biopsy? Like I
Let
did.
me, Moses, good questions. In the interest of time, if I could just start off, is anybody on this call over about 17 and a half years? That's where I am on active surveillance.
You're talking to Moses, but you're the Methuselah of active surveillance.
I'm the Methuselah of active surveillance. And Moses, I quit having biopsies over 16 years ago because I was concerned about sepsis. And I haven't regretted either going on active surveillance or not doing biopsies either.
I think you should caveat that. I mean, some people may need biopsies.
They may need them, and because I chose not to. I tend to be a minimalist, so don't necessarily do what I do, but do your own research. But my story, by the way, and Howard's story, lots of our stories are on our ASPI website at aspatients.org, and you can learn more about them and see our webinars on aspatients.org. I feel like in the interest of not keeping you folks on too long, this has been a wonderful exchange. And we very much appreciate all the questions. We hope it's helpful. And I guess I really, really want to ask you to search your minds to think of men that might be getting PSA tests, might have rising PSAs. This webinar will be online within a week. Bill Manning does a great job of editing. And once it's online, if you could share the webinar with people that are wrestling with rising PSAs, we would be grateful. And we'll see you in another month then. And for those of us that were involved in putting this together, if you could just stay on the call for another 10 minutes or so, we'll chat about our next webinar then. So have a good, for the rest of you, have a great Saturday. Thank you for being here with us today. Much appreciated.